Je pense qu'il ne me reste plus qu'à lui céder la place pour introduire ces deux intervenants pour le troisième panel. Je sais que nous sommes un peu occupés à autre chose, mais est-ce qu'on peut applaudir le docteur Idrissa Beyogo, s'il vous plaît? Merci.
Merci, M. Kamwa. I'm very pleased and honored to moderate this third panel. And it's my pleasure to introduce Dr. Josephine Etowa, who is a member of the Interdisciplinary Center of Black Health. And Dr. Etowa, believe me, is a highly respected researcher. And she holds a Tier 1 Canadian Research Chair in Black Women Health at the University of Ottawa. She's a midwife, she's a perinatal nurse, and she's a full professor. She's a full professor. I'm insisting on emphasizing on that because 3 years ago, according to statistics, there were only 5 full black women professors in Canada. So, no comment. Dr. Etowa's scholarship spanned Black women health, maternal and child health, and the social determinant of health. Her work is grounded in deep community partnership and guided by inclusivity, equity-driven, and action-oriented methodology. Please welcome Dr. Etowa for her presentation. Please.
So I know you've heard quite a bit about Black women, and actually hearing it directly from a Black woman this morning, I think that was quite an awakening for many who don't actually know how severe this problem is. And then Dr. Singh brought that home again with all those stories to illustrate the issues we're talking about. I will not go into those statistics, but I want to remind us of how serious this problem is. That Black women in Canada face distinct and persistent health challenges that require focused attention. These disparities are shaped by systemic racism, we've heard that, and on top of that is the sexism and the social inequalities that come through gender as well. And so I'm going to touch briefly, the 10 minutes I have, I'll use it to touch briefly on the health outcome and systemic barriers Black women face. I will touch on mental health, again, and harmful stereotypes of Black women. This, again, social determinants and how it shapes well-being for Black women, the reproductive and maternal child health disparities, and talk about community leadership in pathways, as pathways to the change we want to see. And so Black women in Canada experience higher rates of chronic illnesses like high blood pressure, diabetes, fibroids, and this higher prevalence of these chronic conditions and the prevalence of cancer in particular, including breast cancer at a younger age, as we've seen. Cardiovascular diseases and perinatal complications contribute to increased mortality for women. The national analysis show, and this is from a Public Health Agency of Canada, national analysis shows mortality inequalities among Black women compared to the general population. Excess mortality are explained by the combination of this higher prevalence of certain diseases, delayed diagnosis, unequal access to quality care. And we heard about some of those. I was particularly moved when I heard this story this morning from Dr. Singh of the woman who worked in the hotel and knew how serious a problem is, but could not take the time off to go through the surgery needed until she died from endometriosis or fibroids. So these outcomes are not solely biological. They reflect those systemic factors in Canadian healthcare system. And beyond Canadian healthcare system, because we're talking about the social determinants, clearly that woman's story was not just about the healthcare system. She had access to a physician that cared and was coaching her through, but she could not even go for the surgery that she knew she had. So It's bigger than biological and even healthcare system alone. So the striking disparities, the case of breast cancer and also cervical cancer at the stage of diagnosis, the registry data linked with census information showed that 26.3% of breast cancer diagnosis in Black women at a stage 3 to 4 compared to 17.0% in white women. So again, just showing some of those disparities. And the other aspect of this is the aggressive subtypes of cancers we're finding. The higher rate of triple negative breast cancer among Black women, so 20.5% compared to 9%. So that's double when you compare to the mainstream. Excess mortality, so among women aged 40 to 49, breast cancer mortality is approximately 1.4 times higher for Black women compared to white women. Screening, the concern that policies initiating screening at age 50 disadvantage racialized women who often develop cancer earlier, raising the question about targeted screening age and also access to services. Cervical cancer, the disparities in screening, access, and also follow-up of abnormalities, highlighting the need to adapt to programs and care navigations. And then we talk about those lived experiences. Just last week, there was a study launched in Toronto by the Black Women's Institute for Health. They did qualitative studies there. The Unheard Voices report was just released, again, speaking to these systemic barriers to access, the feeling of being ignored, misunderstood, stigmatization, and repeated experiences of racism in care. So we've heard these issues of systemic racism. The recurring theme, again, in this new study just released last week or 2 weeks ago, November 4th, speaks to the lack of culturally competent providers, the low representation of Black professionals, inadequate clinical communication, and insufficient care coordination for follow-up. Again, what is the impact? The delays in screening, the late diagnosis, the institutional mistrust, and reduced use of preventive and oncological services is a problem. So the key message here is, without intervention centered on the lived experiences, policy will remain incomplete in terms of truly addressing the needs of Black women. And mental health, of course, we've heard about mental health, but again, Black women experience chronic stress and trauma related to racism, sexism, economic situations, and these factors then increase their risk for depression, for anxiety, for post-traumatic stress syndrome, or disorder and other disorders as well. Many of these women learn to push through emotional pain, leading to delayed care and higher stress. Providers also may misinterpret the resilience they see in Black women as coping mechanisms, leading to underdiagnosis. And when you talk about this, I particularly want to point to these cultural expectations that Black women must be strong, self-reliant, and unbreakable, something that can make it even more difficult to seek help. It's interesting because 25 years ago, I studied the myth of the strong Black woman here in Canada. We published in that. And we've been talking about this, and it's still 20-something years later, it's still coming up in studies, the myth of the strong Black woman that is unbreakable. And so there's so much expected of her, even as she's breaking down. So compounding this issue, again, is that lack of culturally responsive mental health services or low representation of Black professionals to bring some of this data to our work in practice, in clinical practice. How do we transfer this? It's one thing to have the policy. It's another thing to make sure that clinicians are actually using these policies and are actually using current evidence to inform the practice. So the result is a circle where mental health needs are overlooked, support remains limited. And so back to the social determinants. Again, these determinants shape what's happening, the stress we're talking about, the income, all my colleagues, you've spoken about determinants, the social determinants of health. And that is why this interdisciplinary collaboration and the work we're doing at the center is so important, because it allows us to look beyond our disciplines, to cross and look at what we all bring to the table from our different disciplines, to be able to understand the issues around employment, income, education, housing, migration, food insecurity, and others. These conditions then, again, create the stress we're talking about. And so it is so important for race and gender to be recognized as they intersect to create the meaning that Black women experience in their various health conditions. Reproductive health, again, we've heard what's happening in that from the discussion we've had from the other presenters this morning. But again, they face higher risk of maternal complication and worse outcome in pregnancy and postpartum care. And so this is data from Ontario in 2012 to 2019 that shows that pregnant women face increased risk of several adverse outcomes: stillbirth, premature preterm birth, gestational diabetes, preeclampsia, placental abruption, emergency cesarean section, low birth weight, and higher emergency department admissions. So preterm birth rate among Black women is 8.9% versus 5.9% among white women in this 2022 study. Even after adjusting for social factors, these disparities persist, indicating a direct role of structural racism and clinical bias. And so increased risk for neonatal health and disadvantaged health trajectory from birth. We see that as a consequence of these issues. One of the issues I used to talk about a lot as a labor and delivery nurse was how when babies are born, at 1 minute of age, the Black baby is already disadvantaged, because we start assessing circulation, the ABGA score, in terms of circulation and what the extremities look like, whether it's blue or pink. And the Black baby does not necessarily look pink. Even when they have good circulation, they still do not look pink in the extremities. And so they score 1 out of 2. They've already lost a point at 1 minute of age. And so the disadvantage just continues. So gynecological and reproductive, again, conditions, uterine fibroids, that was already illustrated greatly by Dr. Singh's presentation. So these issues remain major problems that we truly do need to address. Community leadership in terms of way forward. Community leadership and culturally competent safe care is important. Black-led initiative across Canada demonstrating how culturally rooted, community-driven solutions improve health outcomes. And so this effort offers care that is culturally responsive and safe and grounded in the lived experiences of Black women. So it's built on trust and partnership. Policy change is essential to support the kinds of progress that is happening with some of the work we're seeing happening in our community. Taibo Community Health Center is one of those leading that work in Toronto. And a number of my colleagues here in the room, Women's Health in Women's Hands, have been leading some of this kind of work happening in the community. But policy is necessary to support the progress we've made. More Black representation across healthcare professions, anti-racist and trauma-informed and violence-informed training is necessary for providers, and equity-focused funding and policy decisions. Black communities lead, it is important when Black communities lead, interventions become more effective and respectful, and Black women voices and their needs are centered when they lead. Almost 1 minute, okay. In terms of recommendation, I'd like to highlight these 5 key areas. Build equitable systems and policies that dismantle discrimination and address structural barriers. Increase representation and leadership for Black women across all healthcare services. and deliver culturally grounded, trauma-informed mental and reproductive health services. Collect and use race-based health data to guide informed decision-making and monitor progress. So accountability is a key part of that race-based data collection. Invest in and strengthen community-driven solutions led by Black organizations and Black leaders. And we will move to quick question. So in conclusion here, before the question, improving Black women's health is not only a medical challenge, it is a matter of equity and justice. And so we cannot really focus on what we can do with the medical system. Transformation requires systemic change, community partnership, and a commitment to truly listening to and valuing Black women. And I have some questions, reflective and actual questions. Thank you. Okay.
So thank you, Dr. Etowa, and we will go straight with the presentation of Dr. Simpson. Dr. Simpson is a member of the Interdisciplinary Center of Black Health, and she's a pediatric hematologist, oncologist in the Division of Hematology and Oncology in CHIO, Child Health East Ontario Hospital. Her major clinical and research interests have centered upon health equity, health system improvement for children and adolescents with sickle cell disease and other chronic hematologic disorder. She's currently the head of division head for CHIO Hematology and Oncology. And with this new position, Dr. Simpson look forward for opportunities to represent the interests of oncology patients and families. Please welcome Dr. Simpson for her presentation.
Hello, good afternoon, everyone, and thank you for the opportunity to speak on this momentous occasion. And I'd like to start off by saying, as a Black physician, Black pediatrician, Black woman, and Black mother, I feel very compelled and deeply invested in our efforts to mitigate and eradicate the disparities that affect Black children and youth in Canada. Okay. So there are clearly disparities when it comes to the research and systems and social determinants that shape health determinants and outcomes for Black youth and children in Canada and globally. There's a scarcity of clinical, epidemiological, and health services research that relates to the health of Black children due to a lack of interest, coordination, and funding. Our health system continues to be challenged by systemic and structural inequalities that create differential access to opportunities and care and to promote physical and mental health. Social determinants of health, including income, economic stability, access to education, health and health care access, housing and environment, and social and community contexts will continue to shape the health trajectories from early childhood for our youth and children. These are inequalities that are cumulative over a lifetime and will contribute to the poor health and social outcomes into adulthood. So are we all born equal? Not quite. And there are numerous examples of health disparities that emerge for Black children from birth, as we heard from Dr. Etowa. Although there's a scarcity of race-based data in Canada, Black infant mortality is known to be higher than that of the general population, and this relates to increased perinatal and maternal risk factors for early infant death, including higher rates of preterm birth, infants of small gestational age, and low birth weight. And so as Dr. Etowa had touched on, we have some Ontario data that shows that for preterm delivery, these account for 8.9% of Black births compared to 5.9% of white births. When it comes to maternal risk factors, there are higher rates of Black maternal exposures to chronic stress, systemic racism, poverty, and unstable housing, which will all increase the risk of these disparities. Black women often receive less personalized prenatal care and will, as a result, also experience racial bias, discrimination when it comes to pain management and clinical communication. It's important to note that in Canada, although there have been increasing reports to support these very concerning trends, there still is a lack of research to clarify the patterns, barriers, and potential solutions for these disparities. So it's clear that certain health conditions like sickle cell disease, malnutrition, asthma, and childhood obesity are more common among Black youth and children, and there's an urgent need for us to better understand the factors that will influence the rates and trajectories of these conditions. So starting off with sickle cell disease, you may or may not know that this is actually the most common inherited disorder worldwide, and yet it remains understudied and underfunded. And so as a result, when it comes to patients that I see on a regular basis, there are continuous systemic and significant gaps in pain management, treatment, and there's limited access to therapies such as novel therapies that have been approved in other parts of the world and access to compatible blood transfusions. When it comes to nutrition and access to healthy foods, Black youth and children will have limited access due to proximity to stores that provide healthy options, the cost of food, and the quality of the foods that are available to them. When it comes to housing, Black youth and children are overrepresented in environments where there are poor housing conditions. They're exposed to poor air quality and overcrowding, as well as substandard housing, which will exacerbate their risks of respiratory and metabolic illnesses. So these are all conditions that will create and perpetuate a cycle of poor health that starts in childhood and continues on into adulthood. So again, when it comes to the trends that we see for our Black children and youth, Black children and adolescents will experience chronic stress related to their frequent and unpredictable exposure to racial discrimination and social surveillance. Mental health disorders remain highly stigmatized in the Black community, but Black children remain at increased risk of developing anxiety, depression, behavioral disorders, and low self-esteem. Black youth are frequently misdiagnosed or over-pathologized because of our biases in clinical medicine, and we must provide better access to culturally appropriate support. The physical and mental health of parents will influence the health of our youth, and so we must provide them with consistent and culturally safe supports so that they can help to mitigate the effects of racial and social stress on these families and in turn on their children. And finally, there's a lack of safe spaces in schools and mental health services, which will further exacerbate inequalities that exist in health access and outcomes. There remain many gaps in our understanding of the many conditions that disproportionately affect Black youth and children and their health. When it comes to medical conditions, there are genetic disorders like sickle cell disease that we know are more common within the Black population, but it's poorly understood and studied. We heard about perinatal outcomes and the increased risk of preterm births, low birth weight, as well as small for gestational age deliveries and infants. There are increased nutritional deficiencies among the Black population, such as vitamin D deficiency, and we also know that there are higher risks and rates of HIV and malaria, which remain poorly studied in the Black population. You may or may not be aware that there are certain autoimmune diseases that may be more common among Black youth and children, such as systemic lupus erythematosus, but this again remains poorly studied. When it comes to mental health conditions, Black youth and children have higher rates of PTSD, psychosis, depression, anxiety, and stress related to the psychosocial stressors that they're exposed to on a daily basis due to the systemic and structural racism. Many of our children are labeled as having behavioral disorders, and they're often accused of having psychosomatic symptoms when presenting to hospital. But when it comes to subjective health measures, we see that there are lower self-rated health measures and outcomes. There's a higher risk of suicidal thoughts and suicidal attempts within the Black population. Black children continue to experience a disproportionate burden when it comes to physical, mental, and psychological illnesses, and these are often poorly studied, poorly documented, and insufficiently supported within our health system in Canada. So as you probably know, when it comes to health and wellness, it's not determined only by medical care. And although there's a lot to uncover, study, and understand when it comes to the health of Black youth and children, there are known psychosocial, cultural, environmental, and other determinants that will contribute to the health of Black children and youth, and these must be addressed to improve health and reduce health inequities. So firstly, when it comes to anti-Black racism, there's a direct correlation with rates of depression, anxiety, as well as suicidal ideation, stress, and increased risk of HIV infection that comes because of disparities based on race. When it comes to gender and the power dynamics that follow it, girls will experience more psychosomatic symptoms and face barriers in negotiating sexual relationships when compared to boys, while boys must navigate forms of masculinity shaped and constrained by systemic oppression. Many Black children and youth will live in poverty because of structural discrimination in our society, and this will increase the risk of HIV. It'll also limit access to physical activity and healthy nutrition. Although sociocultural factors like religion, culture, and family can be protective when it comes to community resilience, these can actually reinforce anxiety and depression in some circumstances because of ongoing stigmatization around mental health that exists within the Black community. When it comes to the environment, Black youth and children are less likely to live close to spaces like parks or places with higher air quality and be in neighborhoods that are unsafe compared to those neighborhoods that are populated primarily by white children and families. These disadvantaged areas are also linked to stigmatizing beliefs and higher rates of HIV. When it comes to access and the use of health services, we saw during the COVID-19 pandemic that uptake of vaccination is not readily available because of beliefs within the Black community, but also disparities in access. Similarly, when it comes to HIV testing, dental care, and mental health services, these are not as readily available to Black children and youth. Access to these services could be improved by improving health literacy as well as health relationships. However, we know that there's a high level of mistrust when it comes to medicine in the Black community, and this is also influenced by the high rates of poverty and the lack of Black health providers in medicine, ongoing discrimination and bias, as well as race-based discrimination in medicine that prevents access that's equitable for health care. Finally, when it comes to lifestyles and preventive practices, there are known protective factors, for example, condom use, seeking health information, as well as religious or cultural participation, but this is limited somewhat within the Black population, and we see higher risk factors that lead to negative health outcomes associated with early sexual activity, tobacco, drug, and opioid use, as well as poor diets that are linked to stress and obesity. It's clear that when considering psychosocial and cultural, as well as environmental determinants of health, that the health of Black children and youth will be shaped by a complex interplay of these factors, and this underscores the need for holistic and culturally responsive care that will help to mitigate the impact of these social and systemic determinants of health. Okay, thank you. So there are numerous healthcare inequities that continue to be pervasive in our health system. So when it comes to access to a family physician, many Black children do not have access, and this is exacerbated with current issues in certain jurisdictions, for example, in Quebec, which significantly impacts our Gatineau patients. When it comes to health services, they often are not culturally safe. They're laced with implicit biases that will affect the quality of care that we deliver and our diagnosis and treatments. There are 4 dimensions across which these inequalities will manifest. Firstly, accessibility, depending on where you live and how much money your family has access to. Adaptability with respect to the healthcare system's ability to flex when it comes to providing services with cultural sensitivity and language that's appropriate. Effectiveness and quality of continuity of care. And finally, safety, which relies on having a trusting relationship between the provider and the child and family, and a relationship that's absent of discrimination. These are inequities and barriers that will continue to hinder care-seeking behaviors from Black youth, patients, and families, and lead to issues with disease prevention, hinder follow-up, and prevent early detection of chronic and mental health conditions. Dr. Etowa touched on the living conditions and social determinants, so I won't spend a lot of time here, but it's clear that when we talk about the social determinants of health, Black youth, children, and families are more impacted and overrepresented among regions with high levels of poverty, as well as parents who are exposed to working conditions that do not promote healthy behaviors or access to positive health outcomes and supports. So these are all determinants that will accumulate over time and create the foundation for the intergenerational health inequalities that we're very well aware of in the Black community. When it comes to health research, you can't understand or rectify what you cannot or what you refuse to see. And so when it comes to Black children in research, there are very few studies that will specifically focus on the needs and health of Black children. We are all very aware that there's a lack of race-based data when it comes to public health databases. When it comes to those who conduct the research, there aren't enough Black researchers who are organizing these studies and asking these important questions about our populations. And then when it comes to funding for these research studies, there's no dedicated funding for Black health, which makes it even more difficult to be able to conduct these meaningful studies to understand the impacts of race and racism on the health of our population. When you're invisible, this will reinforce inequalities by hindering the development of evidence-based policies to address these disparities. So as we move towards equity, the goal is to build communities that are strong and to break the cycle of vulnerability that affects Black youth and children. And we'll do this by addressing social determinants of health, by supporting parents and families through integrated community health programs, by promoting the social and community inclusion of Black children in schools, recreation, mentorship, and other safe spaces, and by having an improvement in access to funding for research, as well as community-led initiatives by Black leaders, including researchers, healthcare providers, and others who can have a positive impact on the health of the Black community. And finally, and probably most importantly, we must ensure inclusive and anti-racist public health governance that's grounded in data, including race-based data, and community knowledge to help to mitigate these inequalities and improve the health of Black children and youth. So that's, thank you.
Thank you very much, Dr. Simpson. Merci beaucoup pour votre attention. So we have 12 minutes left. So please address your question if you have. If you don't have, I will be pleased to pose my question. Maybe a question to Dr. Etowa. I know that you are a champion in peer equity navigator. And could you please say in a few words, what is the state of the art and what have been the added value in practice in terms of the outcome of your research?
Thank you for that question. So the peer equity navigation for Black community is a program, actually implementation science project we've done for a few years now, using it to reach those communities and areas that is hard to reach, where we train people from the community. So it's a community-facing intervention that addresses the health needs of Black community by advocating and mobilizing Black communities to use the available services. We have a training program at the University of Ottawa, the Critical Health and Racial Literacy Training Program with 6 modules that educates them on the history of Black Canadians to illustrate why it's so important to look at these issues, and then goes on to teach them about the key issues, how we address them. It speaks to the issues of inequity and covers these training modules. And people really, by just going through even the training and then having a practicum option where they are partnered with a community organization to learn about the activities that can be done in the community, you see people feeling really empowered to take the issues themselves and go to the community. They go to the mall, they go to different places to promote this. And we've been able to reach so many people. We currently have a 5-year CIHR-funded project to address HIV among Black women across Ontario. We trained over 20 peer equity navigators in 2024. They've just finished their practicum, reaching nearly 10,000 people across Ontario, and in January or during Black History Month, we're going for the next cohort of peer equity navigation program of navigators across Ontario. We have sites in Windsor. The Windsor area covers London, Ontario as well, sites in Toronto that covers up to the Peel region, and the Ottawa side that covers up to Kingston. And we are seeing women actually talk about how this is helping get the information to the community. And the goal is get to the community, work with people in the community. I see Suzanne here, and I'm just thinking about even how the peer equity navigators work in with your team at Somerset West in the last community outreach you did for screening, helping to go there. They're not replacing the providers we have now, but they're going to boost the work to reach the areas that the current people working in the system cannot reach. And so if there's a program that is happening on screening, they visit the churches, the mosque, the mall. They've been nicknamed the foot soldiers. They get into those hard-to-reach areas and bring community members to take up services.
Is there any question? I guess you may ask Suzanne to say a few words about that.
Sure, and we've published paper on this as well in terms of impact. Our second paper is under review, looking at the impact. Suzanne, you want to make a comment?
Yeah. Take me.
Well, I would say thank you for the plug, but I think you actually hit it on the nail. It's one thing to offer the service, but it's another thing for the service to be accessible.
Yes.
So what the foot soldiers do is really help to open the door. And I know many of us have covered this throughout the conversations. There continues to be some maybe skepticism or reluctance to engage within health services in what we might want to call mainstream services. So the foot soldiers, yet again, help to reduce some of that trepidation and help with, with the uptake and the usage of the support. So thank you, but I don't think it's Somerset West. I think it's the collaboration and it's the partnerships and it's the commitment to our community. And I will say that every staff member at Somerset West has completed the Critical Race Health Literacy Program. It's accessible and it's excellent, and that's leadership, right? Wanting to ensure that we're able to use the resource and really ensure that we're embedding it within our organization. So thank you for your work.
Thank you. Thank you. CIHR funded us to pilot for 300. We've exceeded 1,000 now, and it's still growing with requests coming. Yeah.
Thank you. Thank you for a very nice presentation. My name is Aldani Roy. I work at Santé Québec at a mental health direction. And my question is for you. As you mentioned about, 26.8% of women are being diagnosed at stage 3 and 4 for breast cancer. And as we know, when they're at stage 3 and 4, that means they're going to have a chronic disease. They're going to have to weekly visit to the hospital for chemotherapy. And my question will be, could we have more intervention, like, putting access more on preventive, preventing from them to, access care and knowing that they are at stage 3 and 4. I'm talking about, a personal experience about, women being tested. We all know that, the age of screening was reduced all the way to 40. Yes. Especially for us to know, for these women to, being detected plus tôt. And also for Black women, a Black mother, for example. I'm going to take a specific example. Like a mother with 4 children and going to a centre de radiologie, like, with who am I going to leave these 4 children with? And those centres de radiologie, they open from 8 to 4. They close at 5. They don't open on Saturdays. They don't open on Sundays. And would it be better to say that for these, specialized centers to offer more access for these women, especially those screening centers, to offer more access for these women especially, those Black women that cannot attend at those normal hours because they're working. And sometimes, even if they're not working, they're looking for, more hours to work, especially since, ils n'ont pas assez de revenus, puis ils vont aller trouver d'autres heures. Puis si c'était des heures beaucoup plus accessibles, je suis pas mal sûre qu'elles iraient. Puis je pense que, est-ce que pour vous, des interventions axées beaucoup plus sur la prévention ne seraient pas nécessaires pour que ces femmes puissent ne pas être comme diagnostiquées à un stade 3 ou 4? I have a second question, but I'll let you answer.
You're going to interpret some of those for me. Okay. I think actually your question really points to clinical practice, how we can make services more accessible. So the peer equity navigators can encourage people to use these services, but what you're really getting at, it's actually even the hours of work that makes it impossible for them to manage the things that they have to do at home. And I think I want to also direct some of these questions to the people from practice settings we have here. And again, there are some people even here in Ottawa that are implementing the Black Health Plan, they're doing screening again. So are there things we're now planning to do that addresses issues such as this, where the situation you just described makes it difficult, even if the woman was motivated to go in and use the service, she can't do it. It's interesting because in our training program, we put in scenarios such as this, that somebody not showing up for appointment does not necessarily mean they don't value the appointment. It's just the difficult situation they find themselves. Even taking time off from work to go to an appointment is not an option for some people. So I would like somebody who is working in practice or policy.
I could add that even from a...
Sorry, and so I was just going to add to that because, so I'm a pediatric hematologist and my practice primarily is related to sickle cell disease and other non-malignant hematologic disorders. And so we do see it quite often that, our structure does not suit the accessibility or the lifestyle of a family to promote their engagement with the healthcare they need. And so, in the last year or so, we had an additional sickle cell clinic that was added another day during the week, which made it more available and accessible to families who couldn't come beforehand. But I think we have to be very flexible in our practice. We're very fortunate to have a very strong clinical team where we have a nurse case manager and social worker who work with families. If they miss an appointment, they will follow up to find out how we can get them there. Sometimes it means that we have to see them in a non-sickle cell clinic, sometimes on an off day, and that requires a lot of flexibility. But at the same time, you can't rely on the goodwill of the clinical team. You need the resources to make it sustainable. And so I think that you're right that it has to come more from a structural, systemic kind of perspective for it to truly be accessible in a sustainable way.
Thank you.
Second
And-
question?
Yes, and also, yeah, my...
Just to add, we did also a project on social prescribing, which is having navigators for social services. And what they did when people, like the person she was talking about, is the navigator also found somebody to keep the children or to take care of the children while the mother went to the test, because this is a difficulty, absolutely. And there are other solutions. We should be moving to mobile mammographies or that sort of thing, where they go into the communities to do it.
Thank you.
And when you look at an efficiency, lenses also for a health system, it will be more efficient to go on preventive services, to say that, okay, let's try to make those women come before 40. Let's try to make them come with their children. Whatever is done, instead of caring for them when they are already at stage 3 and 4. Yeah. It's going to be, you're going to spend much more money, taking care of these women instead of, just doing the preventive, step.
And just to add to that, so Quebec, unlike Ontario, only screens from age 50. But in Ontario, it's from age 40.
Yeah,
so that's another
good.
point of advocacy that makes a big difference. Mm-hmm.
Okay. And then also it was about the APGAR, when you mentioned about the APGAR being,
yeah.
And I know that Canada is an avant-gardist position in everything. And as you mentioned about the APGAR, I'm a doctor. I've been practicing for 25 years, and I have heard it since '92. So I'm like, okay, at some point, and we know that it is the same situation in dermatology, in respirology, and in many fields. I would appreciate that even we know as we gathered here, so we can take a standpoint for all those, like structural discriminatory procedure that are like oriented, not being very inclusive, integrating, like, there's other skin colors. For them to, I mean, with all the respect to the nurse Abgar, I forgot her first name, but, sorry? Virginia Abgar, thank you very much. With all the respect to what she did, but I believe that in Canada, we have had this very strong position of, taking a standpoint and saying, okay, from now on, this is what we're going to do. And I believe that with our voices here, we can also say that, okay, let's try to change it to another tool that will be more inclusive.
Yes.
Because, it's been so long. I'm going to leave the profession, and I feel very sorry that even if I leave the profession, we're going to still use APGAR saying the baby has to be pink. No, the baby can be any color.
Yes.
Thank you.
Merci pour Dr. Etowa et Dr. Simpson. La police du temps est très dure. Donc, je voudrais vous inviter, si vous avez des questionnements, if you need to further interact with all the presenters, you can direct your question directly to them or through the Interdisciplinary Center of Black Health. Do not hesitate, please. So, thank you.